Hi, can you all hear me on the live stream? Perfect.
Amanda, I can hear you.
Okay, Nana, we have one person on the live stream right now.
Okay.
So this is the mic that we use for it won't,
Okay.
it won't create audio. It will just, you're basically just talking into the mic for it.
Okay. So we
Or you can have multiple speakers actually.
okay.
Yeah.
Okay, cool. We can use both.
Yes. Yeah,
Okay.
Sorry.
Okay.
Yeah. Now it's
Okay.
Check.
Okay. All right, cool. Thank you.
So Kelly is using the mic. Oh, got it. And then this, yeah. And then this is the one that.
I should have said this. You only have to hand out this one.
Oh.
These are the same thing,
Oh.
except I didn't want to print the full guide for everyone. So these are for handing out during the plenary. These are for everyone.
Give it to a friend. We're gonna say it. We're gonna say it forward.
The guide you should have gotten is a couple of pages. So if anyone doesn't have your
Robert the closest Starbucks.
you want the one that has staples on it. Yeah. When we're introing yourselves, do you like share how we first heard about MHS?
Ooh.
Might that be?
I just looked because I was like, wait a minute.
Yeah, sure.
Ready to
remember.
start it?
Okay, yeah.
Yeah.
Yeah, sure.
Okay.
That's cute.
Yeah. Are you all ready? Oh, yeah. I'm gonna.
need to use the mic. Okay. So that the folks on Zoom can tell right.
Hi, everyone. Welcome. I'm going to try to remember to project because this isn't a working mic in the sense of making my voice go further out. Well, and I remember my mind was blown and I did what I do and I went online and I Googled everything I could about it. And I found this CDC funding document and I was reading through it. I was so appalled because it like wrote MHS into it, like showed it to Nana. I was like, do you know about this? And Nana was like, yes, that's why we're here. And so we'll be talking about this a lot more and how the federal government funds and compels molecular HIV surveillance. But now I'm going to turn it over to Martha.
Sure. Hi, everyone. My name is Martha Cameron, she, her, hers, and I'm here among many organizations representing people living with HIV caucus. And I first heard about MHS at AIDS Watch, I think it was 2018. And so we heard about it in DC, and the local people in DC immediately challenged our health department about it. So I was really like fired up when I heard, this was being talked about in AIDS Watch, and I hope you all know what AIDS Watch is. But it's a convening in DC where we visit we come together as advocates and visit our congressional representatives.
Hi, Robert Suttle. I am a community member with the U.S. People Living with People.
Even though the research side, you can't forget that you can't just love of science and the technology and then not forget the impact that science, how you move it along, will impact us later. So I've worked on both sides.
Hi, everyone. Nana, Khanna, they or she pronouns with Positive Women's Network. I think I first started to hear about molecular HIV surveillance also in 2018, kind of earlier in 2018. There was a paper that came out that Project Inform, if y'all remember that organization out of San Francisco. They're no longer around, unfortunately, but they had commissioned or been commissioned basically to put together kind of a consensus paper from allegedly like the HIV community on this form of surveillance that the CDC was planning to roll out in a really broad way. And then this paper came out, and we started asking at PWN, hey, did anyone know this was going on? Who was involved in this? That they're speaking for community. And we looked at the organizations and the list of people who had been involved in these consultations, and there were like out of 50 people, there was like one person living with HIV in the mix, and it was somebody who was like a CEO of a very large organization and not very connected to the grassroots. So that kind of set off some alarm bells, and we started to do some more digging, and I'm sure we'll talk about that more today.
Thank you, everyone. All right, so a little bit about what you can expect today. We're going to start with a grounding on what is MHS. So there might be folks in this room that are very familiar with it. There might be folks who are relatively new to the concept. So we'll try to do some level setting. And then we'll go over some concerns about MHS. And then we're going to go into a discussion. It says pair share here. Ignore that. We're not doing that. We're going to do a large group discussion so that our folks who are visiting or with us online can also participate. And then we're going to talk a little bit about how to take the advocacy home. All right, so first off, I'd love to just get a temperature of the room. How many people know what MHS is? Okay, okay. And I'm wondering if we could get a couple of people to just tell us, you know, what brought you to this workshop? Why are you here?
Hello, everybody. I just started saying it recently this year, and I just got curious because I know it has to do with exposure of identity of people living with HIV. So and I wanted to know more about it. That's why I'm here.
Thanks. I'm a lawyer and I always look at things like who's the bad actor, who's the person that we can represent, how can we make this, better, through a legal lens. And as we were talking about at lunch, this is so insidious. It's hard to figure out who's the person that's actually harmed. And we don't want to wait till we see the actual harm. So I'm here to think through some ideas about how we could proceed.
Thank you.
Hi, my name is Sylvester, and I also heard about MHS early in 2018 because of the Virginia Department of Health.
BARB CARDELL 792. So you're going to text that to the number 22333. And then once you text Barb Cardell 792 to that number, you're going to be able to participate in this survey. And so we're trying to get a feel of a couple of folks in the room, a good number of folks have heard about MHS before. We want to know how you feel about it. So if you are very, very favorable, you think MHS is a great idea, you'll put in A, B for somewhat favorable, C for neutral or unsure, D for somewhat opposed, E for very opposed. And I'll give folks just a couple of minutes to do that. Yes.
The number is what you put in the two, and then in the chat you put the name.
Exactly. Yes. Thank you for that. Yeah. Yes.
Oh,
The poll isn't active.
you text BA, text that to 22333.
Yeah.
After it is gone.
Okay. It should be active. Barb Cardell 79. There we go. It's working. We're seeing responses come through. I don't believe they have to be. I don't think that matters. All right. So again, in the to line, you're putting 22333. 22333. And then in the text of it, that's where you write Barb Cardell 792. All right. So we're seeing folks who are somewhat opposed, who are very opposed. Awesome. Well, great. So I guess we're done. This was a good workshop. Thanks, everyone. Glad we're aligned. All right, so we're about 50-50, somewhat opposed to very opposed. Thank you for that. All right, Okay, so what we're going to be talking about today is molecular HIV surveillance. And so I'm going to give you a little definition of what MHS is. This is from a really amazing paper called Molecular HIV Surveillance, a Global Review of Human Rights Implications, that talks about MHS in the global context and gives very particular examples from different countries, including the US. So if you have some time, I highly recommend that you look there. But what they say there is MHS is an umbrella term that describes a wide range of practices focused the term MHS CDR, molecular HIV surveillance, cluster detection and response. And so we're going to dig into a little bit more about how MHS actually works, because oftentimes that can be clarifying for what MHS means. And with that, I'll turn it over to Nana. And yeah.
Oh, okay, great. Cool. So I'm just going to go over a little bit about like, what is this data? How does it get into the system in the first place? Okay. So I'm a person living with HIV. I go to my doctor either when I'm first diagnosed or when I'm engaging in regular medical care. If I need to switch my treatment or go on treatment for the first time, what are they going to do? They're going to do a resistance test, right? To make sure that they're giving me meds that will work for my virus. So my provider is going to order a resistance test. In order to do that, they take my blood. They basically sequence my blood. They sequence the HIV virus, like the genome of the virus, to look at exactly what mutations have occurred or haven't occurred, because when you take medication, you can develop resistance through mutations. So they're basically looking at that. So that's what this step is. The laboratory is performing genotypic testing. They're putting together a genetic sequence, they're comparing it to see if there's any mutations, so that they can make a recommendation. So my provider can make an informed recommendation to me about what medication options I have available. So that information is going to come back to my provider so that they can give me advice and guidance, right? About what I might want to take. But also, that HIV sequence that they get is also reported to the health department. It goes to state and local health departments. It also goes to CDC. CDC gets all of this data in a large database. It's my personal information has been removed at this point by the time it gets to CDC, but they're basically looking at all of these long genomic sequences and they're comparing them. Their computers are doing this. Humans are not really doing this. Computers are doing this really fast. And what they're looking for is, are there genomic sequences that are really similar to each other that are showing up within a short amount of time? So technically what they're looking at is, within like a 6-month period, are there multiple sequences coming in that have less than 0.5% variation between them? So it's like 99.5% similar, right? Because what it means to them is that maybe it looks like these viruses are related to each other. Like they are either from the same source, or like somebody, there's somebody in the mix that like probably somebody got it from somebody else, or both of you got it from somebody, or whatever. So they're using that to basically inform public health responses at that point. So this is what they call clusters. When they identify a bunch of sequences that seem to be closely related to each other, they call that a cluster. Have folks heard the term cluster used? How does it feel to be called a cluster? I know. Clusters can be so sweet, but not HIV clusters. So basically then CDC goes back to the health department and says, hey, it looks like there's a bunch of viruses like in your area that are related. Or they can also compare it across state lines, because this is CDC, right? This is federal. So they're comparing across state lines. They're comparing across jurisdictions. They're saying there's like 80 that have come in that all look related. Maybe it's like in New Mexico and in Arizona and in Texas. What's going on? Y'all need to look into this and do some investigation, and we need to mount a public health response. So that's basically what molecular HIV surveillance is. some of the problems, like, probably that you can see even just like looking at that chart are, we didn't know that was happening. When I go to my medical provider, thank you, you're the best. When I go to my medical provider and talk about switching meds because like, because my Biktarvy is like making me gain weight and feel miserable. And I'm like, I need some better options. This is for real, right? I don't necessarily know at that point that they're going to be reporting my data to CDC, and it's going to go into this database that I did never consented to. So anyway, we'll talk about that more. Yeah. Yes, please.
In some jurisdictions, I'm not sure, it was everywhere. They stopped just doing it only when you're resistant. It became routine that they started collecting this without our consent. So they would draw the blood and you wouldn't even know that your genomic testing is being done. It wasn't just because a few of us become resistant only at certain times, but in like my health department, this became routine collection, the genome.
Yeah, thank you. You can hold on to that. Yeah. I'm sure you'll have more to add. So we can go to the next slide. So I think this gets to the point of where is MHS being used? I see your hand. I'll come back to you in a second. Thank you. So where is MHS being used? Well, it's really being used in many places at this point. Not just in the US, but globally, because we like to export things that are really bad for the rest of the world. We do that a lot. That's what we did with HIV criminalization laws too. So MHS is just another example of an oppressive public health practice that has been exported around the world as well. And then here in the US, there are it's being used in like pretty much every jurisdiction at this point. And that happened because under the Trump administration, when the Ending the HIV Epidemic Plan was introduced in 2018, molecular HIV surveillance basically became a key and required component of the national HIV response. And that's what Kelly was talking about. When she went back and looked at CDC documents, she basically found this Notice of Funding Opportunity, PS 18-1802, that came out in 2018 that required every health department receiving CDC funding to support reporting and monitoring of phylogenetic analysis results. So this had been happening on like a smaller scale in some jurisdictions. New York has been doing this for a long time and kind of leading the way. Washington State is actually another of those states that have been like doing this for a long time and leading the way, and several others. But for the first time ever, in 2018, it became mandatory for jurisdictions to participate in molecular HIV surveillance in order to get funding from CDC to do prevention activities. And so this is really the national rollout. This is a policy that came in the Trump era. This was part of that whole Ending the HIV Epidemic Plan. Trump, in his State of the Union in 2019, January 2019, pledged to, pledged to end HIV. It was, wasn't it the State of the Union 2019 where he announced the Ending the Epidemic Plan? I think. No, because I don't think even he thought he was going to be president. So I don't think he was ready in 2017. Right. Right. So anyway, so in his State of the Union in 2019, he was like, we're going to end HIV transmissions by 2030. Whatever. He got that line from somebody. He said it. But basically, he had rolled out this strategy, and it basically funded a few different areas of action. And one of those was this use of data, which is highlighted here in the second bullet point, using data to identify where HIV is spreading most rapidly, guide decision making to address prevention, care, and treatment needs at the local level. They also talked about, geographic hotspots. So this MHS approach is part of, and cluster detection response is part of identifying those geographic hotspots. Where transmissions seem to be growing or where there seem to be more transmissions, and then creating this local HIV health force in those areas. So in the first graphic that came out from CDC, from the White House about this plan when they announced it, the very first graphic had 4 pillars of the Ending the HIV Epidemic Plan. And it was, diagnose people as early as possible, treat HIV, protect folks using prevention, using PrEP basically, because, Gilead funded a lot of this, and respond quickly to detect and respond to growing HIV clusters. And the HIV health force will establish what? Can anyone see what that says? Say it louder, Robert.
Elimination team.
Elimination teams. They were going to establish elimination teams in each jurisdiction to ensure the success of this initiative. Well, we were a little concerned about that language and the implications of it. What are they trying to eliminate? Who are they trying to eliminate, right? So you can go to the next slide. They took this graphic down with the quickness. This might be one of the only existing screenshots of that graphic that is still out there, and they have replaced it with something else that sounds very neutral. So I guess basically in summary, we have a bunch of concerns and we're going to talk about them in more detail. And we're also going to have a big discussion with y'all about what you think and your concerns and what you think we can do. But our concerns, just in brief, are, number one, this process requires no consent from people living with HIV. And that is a violation of our bodily autonomy and our human rights. We should have the option to consent. We are also concerned that, we're here to talk about abolition. We're here to talk about how surveillance and state violence create vulnerability for our communities. So we have to explore, it is imperative that as advocates for decriminalization, as advocates who are trying to protect our communities from the harms of over-policing, that we examine how these kinds of surveillance and data tracking systems can exacerbate vulnerabilities, especially for Black folks, especially for Indigenous folks, Latinx folks, people who are queer and trans, sex workers, people who use substances, people who are unhoused, our communities who are most vulnerable already to over-policing. There are no real protections on this data, and that's something that we'll talk about in more detail, because usually when we look at this stuff, we're like, okay, cool, but there's HIPAA and, there's things in place to protect us. No, the answer is no. There's actually no consistent protections on this data from a state to state level. There's substantial variation in what kinds of data sharing is allowed, where data is stored, how it can be demanded by law enforcement, and in different kinds of civil and criminal proceedings. Also, MHS and CDR cluster detection and response can lead to inappropriate disclosure of personal health information, which can also lead to violence. There are concerns that the focus on molecular HIV surveillance and cluster detection and response can actually be exacerbating racial inequities in our in the HIV epidemic response. And we'll unpack that a little bit. Martha's going to unpack that for us later. And hey, they never talked to us about it before they did it. So there's no MIPA in this process. We've been talking this whole time, right, about what it means to have meaningful involvement of communities who are most impacted. No, CDC said they consulted. They did not consult. They have so many people living with HIV networks that they could have reached out to: Zero Project, Thrive SS, PWN, Positively Trans, National Working Positive Coalition, the US People Living with HIV Caucus, the long-term survivors. There are so many different groups they could have reached out to talk to, who have access to hundreds or thousands of people living with HIV. No, they included one person who was a CEO of a major organization and said, oh, we consulted with community. So these are some of the concerns that we'll be unpacking today in this session. And I think with that, I pass this to Venita.
So before I talk a little bit about consent, I want to say I was sitting here thinking why I said 2017. Because even though that administration announced that in that State of the Union, MHS had been done in a couple tested jurisdictions, and I live in Houston, and it was one of them. That's why. And so I think I first heard of it probably in 2017, and Houston was part of that pilot before, and we knew nothing about it. And I remember I worked at a FQHC at the time and getting a notice saying, how many clusters was in Texas and how they were working on one, Latinx men, gay men, and how they had an advisory for doctors that says they want them to test people sooner for different kinds of symptoms. Don't assume. And I remember thinking, clusters, what the hell is that? And I called our state health department to ask our person who was in charge of that. So I began asking questions then, but the answers weren't satisfactory. So we had started it sooner than the man announced it. But one of the biggest things that's got me, especially on the public health side, or even on the research side that we've talked about, is this lack of consent. You know, getting an HIV diagnosis is tough anyway, right? And when you go in there and whoever gives you your diagnosis and you keep going back for care. And one of the things I remember I had a problem with when my doctor first called me and she wanted me to come in, and I said, no, everybody knows and all this stuff. And she said, Venita, no one else has seen it. I'll have them. I didn't want to sit in the waiting room. You know, I had been traumatized with this. And she said, if you come in, I have you take it back straight there, you know, to a room and talk with you. And what happens for us when we go in these facilities, we don't know who knows who we are. Case managers, y'all just share. I'm in a room waiting for somebody and they decide, go in there and ask her if she want to participate in a study. That happened once. I'm like, how dare you? I have a hard enough time talking to a doctor and you're going to send somebody in here without my permission to ask me or to bring a student in there. And I'm already, you know, I went through 4 years of depression after my diagnosis. So it was hard enough talking to him. I would cry when you draw my blood. So this idea that, and I was a lawyer at the time, but so this idea that I found out that not only did I felt like I had been diagnosed with something so super big that I couldn't get my arms around it, to know that, you know, how I was stigmatized now you're saying, in addition to that, I'm better about that. You don't need to ask me for nothing. Never mind the fact that once we test positive, we're tracked for the rest of our life. You don't know that when you get tested, right? Or when you test positive. Now you all have taken my lab results based on a conversation between me and him or them or her. And now somebody else is looking at this and they are deciding some new data with it. And I was so offended, I felt violated. So this idea, and when we started bringing these issues up, they were saying that general informed consent was all they needed. And that even though I had no knowledge of this additional testing and this additional things that would happen, that from a public health perspective, they had the right to do that. So not only do we become people living with HIV, we're public health targets and public health, you know, and I always say, fight HIV, not me. I am not the target, you know, HIV needs to be. So it just strips away another level of my humanity by saying I don't have the right. And as a Black woman, knowing the history one more time, and when we look at who is most impacted by this disease, and already the reasons why we are the most impacted, now you've added another layer to that mix of what we don't have a right to say, and now you have a right to surveil. And so this idea of informed consent just keeps getting brushed off when we bring it up, because we no longer have bodily autonomy in the eyes of public health. We no longer have a say-so. And I'd say to you, and if you're sitting here negative, how would you? I believe if people around that table were also experiencing this, we wouldn't be having this conversation. Because when your rights get taken, or when your bodily autonomy and your humanity gets taken, I think the decisions become different, which is why MIPA is so important, and which is why we want people that are reflective of folks in our positions on serving on the boards and bodies that are making decisions that impact our lives. So informed consent, was that what I was supposed to be saying? Okay. Okay. So the fact that another layer of our humanity is taken away and just brushed off like it's not a big deal. And let's be clear, there are no race neutral policies or laws or practices. So you might say, well, it don't have race in it, but if the predominant people who are impacted by that decision are queer or Black or whatever, there's a racial impact. So please get rid of this idea, and let's stop behind in this social determinants of health and call racism. Let's name those other things, because we can hide behind a clean package that makes it look different. But the reality is, if there are no such thing as race neutral laws, practices, policies, or programs, and if you are not analyzing the work from our perspective, you're probably harming us in the practice of trying to do that. And you need my consent, and I'm going to fight you at every angle. Okay. And we, shouldn't you be able to go? I wouldn't even go to the doctor for a while because I didn't want no test because I'm thinking you ain't putting my stuff in there. And now that I know, my doctor will tell you they see me maybe once a year. I don't want to add to a system I don't believe in and didn't ask my permission. So I want the ability to opt out. I want the ability to say, use my stuff for this purpose only and not that. And I think every human being should have that right. No, we still don't. And so I'm going to turn it over to, I think, my good friend Martha to talk about disclosure of violence concerns.
I had to remind myself. So this is on, right? I know this feels really weird, Venita.
That's why I didn't see it.
Okay, so say that again. Were you supposed to? I think you were. And then I'm doing the racial. Okay, I can talk about this, right? So, okay, so imagine seeing that sign in your neighborhood. I mean, this was a real sign in a neighborhood that was posted, right? In Indiana, about it was on a freeway, or was it in a neighborhood? It was on a freeway. I saw another one where it was actually in a neighborhood, and they actually interviewed the Department of Health personnel who confirmed and actually named some of the streets in the neighborhood that they were talking about. What happens when something like that happens in your neighborhood? And who do people start looking out for when something like that happens? The coverage of classes has really, really, really been troubling. And when I think there was another one in Texas. Where's the other one? Yes. So yes, in San Antonio, Texas, which involves Hispanic men. And I totally believe this was targeted at men who have sex with men. Yes. And then, there's that story up there about a transgender woman in Los Angeles, more likely to be in high incidence clusters than any other group. What does some of that communicate, and what does that incur? I remember in my first job ever in an HIV service agency, the first day I walked in, there had been the first homicide in DC. And that homicide was of a woman that was HIV positive. And it was related to her disclosure at work. She was a security person, and her and she ended up being killed. I don't know why. We don't know why it was, but this is what happens. It exposes people and the most over-policed populations already, and they're the ones that get targeted by stuff like this.
The example of the streets, like there's another example in here. This Seattle headline that ran, this article, they're basically saying they're basically like putting into a big newspaper. There's a HIV cluster in North Seattle among drug users and homeless people. And then if you read the article, it names the street they were on. Like, imagine the level of violence that exposes people to.
And I just want to talk about the Texas. So for the CDC for a number of years touted the San Antonio model, and everywhere they went, they would always say the success. I live in Texas. We didn't see the success. And they would always say they did this to deal with stigma. Never mind that in Texas, these were some of these men were immigrants. So imagine what we were going through, the fear when this was coming out, because ICE was everywhere. And it's to use this as a poster child to take around the country and talk about the success of, and those of us in Texas, trust me, I can't tell you about a success. It's not that we didn't know that a community needed those services already. What's new about that, right? But then the success of identifying and dehumanizing them in the form of a cluster that we then take around to sell some science that we haven't even analyzed the consequences and the cost benefit, which has never been analyzed. So this, when you see it somewhere, if you go anywhere else and they keep talking about San Antonio, say, well, I heard for somebody else, and you can say my name, Venita from Texas, and she said that shit was not the way y'all said that. They knew nothing about it. You didn't reduce stigma around it. And even Dimitri has said, Dr. D, that cluster detection is a result of a failed DIS system. And I say fix DIS. Why do we need another level of science and surveillance that could harm us more?
I just want to highlight and make sure you all heard something that Venita just said. One of the things we hear from the CDC, and we'll get to this, we'll get to the ways that folks often push back against MHS. But one of the things that the CDC says is like, this is a tool we need. There is no other way for us to identify these communities. And in doing so, we see the ways that folks are put in increased danger and at risk of violence. And these are communities that we already know are disproportionately likely to contract HIV. And so we already know that these are the communities that need to be reached out to for public health interventions. The cost benefit analysis here, it's weird to say that, right? Because it's disgusting a little bit to even talk about a cost benefit analysis when you're talking about the health, the rights, the security of people living with HIV, and specifically Black and brown, queer and trans people living with HIV. But in this case, like, what is the value added? It's not clear when you're having statements like this out in public. Sorry.
Yeah, and I'll piggyback on that point too. But one of the things that I was going to say, and it's kind of like been said already, is there was no additional level of surveillance needed for people living with HIV. So when you look at jurisdictional maps, or the famous heat maps, so if you look at even the whole country, and they will tell you where HIV is concentrated, it kind of goes darker in the places, right? So it's red, it's pink in the areas where there's no HIV, and it goes darker in other areas. If you use that same heat map for violence, you use that same heat map for diabetes, you use it for high blood pressure, you use it for any other condition, you know that the people who are going to be disproportionately impacted live in those same areas. And so there wasn't any additional surveillance needed for you to target services in those areas. It didn't need, and then our health departments have actually been talking about how when they've been mandated to do this, there has been no additional funding. So they're complaining about how they have to figure out how to pay for some of this and remove it from other programs because now it's being mandated.
Right. And so, as we know, with any type of prevention effort by our federal government or CDC, there's always the consequence of criminalization, which they don't necessarily highlight or talk about, but it is definitely one of our concerns. So, next slide. And so, as you all are aware, since being at this conference, HIV criminalization happens in many states and countries, even when there aren't HIV-specific laws on the books. But there are scientists that believe that MHS has not yet advanced to infer directionality, which meaning direction of transmission. But even if that's true, this is only a matter of time. And because the advances in sequencing technology and analysis that allow inference of directionality of transmission are likely to be available in the future. And we have some examples of that in the next slide. But judges and juries don't always know, care, or understand this science. And so, next slide. Oh, are we missing a piece? Oh, okay, that's okay. So examples that they're based on research in the U.S. as well as, oh yeah, thank you, as in Canada. Molecular evolution proves source of HIV infection in criminal cases. This is like a title of an article, and this is as far as like 2010. And that molecular evolution is phylogenetic analysis, is what it's called. And it says that allows us to reconstruct the history of the infection events. We can identify the source in a cluster of infections because some isolates of HIV from the source will be related to HIV isolates in each of the recipients. So this is like a first case study that establishes the direction of transmission. And again, there was another article in Canada where it was tied specifically to a case. It says phylogenetically distinct form of HIV that Mr. Aziga had the virus prior to contact. So this is someone who is giving comment about this particular practice based on a real situation in Canada. So those are two examples that for in the US and Canada, but then the science also progresses. Almost all phylogenetic analysis have access to some additional information. Otherwise, why would one do the phylogenetic analysis in the first place? And so this is someone from a laboratory giving comment. And that other science progression is also the tool of recency assays can be used as a proxy for directionality. So you have two features here in relates to surveillance that have been proven, that have been discovered. So again, there was one more. So I wanted to read this because this was from one of our colleagues and friends in Canada, Alexander McClellan, says that a prosecution team in Canada used the open access Los Alamos genetic database to successfully convict a man accused of non-disclosure. So while the judge noted that the court could not use the data to prove infection, it was helpful circumstantial evidence, is what they're calling it, that has been widely accepted in legal cases to identify relationships between genetic samples. So there is proof that this practice is, although they do it in the name of prevention, there are also consequences around criminalization.
This is really important because a lot of the pushback that we hear from community about molecular HIV surveillance is they're like, oh, well, can you urge to use to criminalize people? Like, we shouldn't have to wait for that to happen to fix this problem. We're not going to wait. We're not going to do that. We're not. Like, we're already showing you that like phylogenetic sequencing has been used. They are all the same kind of and comparing it to specifically in that Canada case, target is Ugandan immigrant man. So again, you know, xenophobia, racism, anti-blackness, all up in
Immigration.
And then that article from Alex McClellan that Robert just read from is also looking at how they got the data. So they didn't get it from CDC. They got it from the Los Alamos database because our data doesn't only go to CDC. It also can be uploaded into these open access databases that researchers are just downloading from and using for other types of things.
And in fact, that's kind of what we'll talk about in the next slides, where we're saying, you know, is this really data privacy and they're really laws? So if you go to the next slide, I think, you know, one of the things that shocked us in my jurisdiction was that our health department didn't even know that these statutes provide for them to share the data basically anyhow. They have broad, you know, allowances for the health department to share this data. And like Nana was saying, it's used for research. Like our health department was begging people in the DCC and say, look, we have this DC cohort data, we have this data, use it to do your research. And granted, it's de-identified, but here it's data that is given without consent. It's surveillance, it can be used for surveillance, investigation, or control of common communicable. This is sort of their justifications for treatment, payment, research, or healthcare operations. But most importantly, as Venita was saying, it's a justifiable public health need. And there is no justification to where this data can be used in the ways that we have seen it being used. So in our particular case, well, let me just say this, the states do vary about whether they can subpoena this. I think that was a question that the legal person was asking about, you know, whether it can be subpoenaed, but we know that it can. We know that it can. And especially in some cases, a person can even be requested to test again without their consent, like they can be mandated to test again without their consent. And the states do have legal authority to share this data for research, like we've already talked about. Some states require de-identified data, others allowed identifiable data, but publication has to only include the de-identified data. But you see, this is what I think Robert was talking about. A person, especially in legal cases, they can trace it back and they can subpoena the health department to be able to provide that information. And so when we first heard about this, and I tried to give an example of my jurisdiction, we said we wanted to see something in writing that said you will not share this public health data, even though you've been given permission to. And even though they did that, we know that that doesn't stop the legal courts in making sure that they can access that data, whether it's de-identifiable or identifiable. And real quick, I'll also add, I think Nana mentioned HIPAA at the beginning. You know, when we go to the hospital, now it's actually a little pad, right? This says that you agreed to da-da-da-da, sign. This says you agreed to da-da-da, sign. We don't read the fine print, but even when we used to read it, the HIPAA law says that they will not share that information with my partner, with my, if I'm over age, with my family or anything like that. But it actually gives them permission to share with other providers and health departments to help you in your care. And so that also gave them permission broadly, because I questioned one time, I said, we were talking about withdrawing my consent. Where is it that I actually gave consent for my genomic information to be used? I give consent for my blood to be drawn. They'll ask you, what's your name? Repeat your name, Martha Cameron. Date of birth, you repeat it, and then they draw your blood. I don't remember ever saying, you can also take my genomic sequencing, but apparently we did.
Wait, this is the thing. I know who's next, but I want to lay this out. Why aren't we the already harmed person by you? First of all, we gave a consent. It wasn't informed. To me, that's an assault, But secondly, you have violated my privacy and my protections by doing that. Why aren't every person living with HIV already harmed? I know you look for a different kind of injury that, individualized injury. And I'm saying the new look, we are individuals and we have been harmed by having our privacy violated without, we believe, the benefit of an informed consent. So I want to challenge that thinking that says there is no harm when I've already been harmed by you being able to use my bodily fluids in a way that I did not give you an informed consent. Consent by itself is not informed. And the fact that it isn't informed, I don't. But I do realize we do a lot. I call them contracts of adhesion, where you don't feel like you have the right to say no, because if you want it, you gotta say you want it, and it don't matter if you want to read it all. But I still say the harm is already there. My consent wasn't informed, and you have violated the consent by not doing what I asked or not informing me in a way that made it informed consent. Who's next? But it's not there. That's specific. And I know that's not what lawyers look for, but I'm saying we're all harmed. We're all a class. I think we're all a class already, and we've all been harmed. And the harms are continuing without that informed consent.
So we're looking for a lawyer for a class action
lawsuit. She knows I'm looking at. I'm looking at. I just want to get the creative juices. We got to get creative. That they know the loopholes. They know what this, how squishy this is. And I'm saying to you, the case is there. There's no informed consent. Never mind, it's not easy, but our lives aren't either. And this kind of practice will continue until somebody makes them stop. And I'm gonna tell you, the CDC in a meeting, well, we can talk about that later, a meeting in, what was that, last year? And where we were talking more about it, why did they have their attorneys in the room? Office of Civil Rights in the room. But if there's, they did. They were in my breakout group. I said, isn't that interesting? You're a lawyer, why are you here? I'm just listening. No. They're not just listening, they're not. They were in the room for a reason, because there is some liability. And I just thought it was interesting. Who's next? Yeah, just say whom on that. The fact that the consent wasn't informed. Never mind, you say you don't need my informed consent. You didn't get an informed consent. You didn't get anything. Do you say I consented already? I say I did.
Yeah. Next slide. So we kind of already talked about this, right? That we know that the data that they're trying to collect and reflect is already looking at the most vulnerable communities. one of the things that this slide talks about is mistrust. I'm pretty sure it's on this slide somewhere, right? So we know historically what has happened to us. We know historically how our bodies have been used or abused for research, and we know why our community already mistrusts the medical profession. And now that our community, if our community would understand what it means, that our consent is not being taken and our body and our blood is being used to do all this, how would that impact our attitudes towards care? You know, we're already having trouble, especially getting Black women, for example, on PrEP. Why? Why has this happened? We know that how PrEP was rolled out and how it was researched and how it was done did not even include women. Well, it kind of did, and then they left us out. And we know that the new PrEP didn't even include women in its clinical trials. But I'm talking about this historical mistrust of the medical profession, because we know that CDC undermines trust in the healthcare system and public health infrastructure, especially for our folks. We also know that some public health officials have expressed that they're reluctant to conduct CDR because they know who it impacts. They know that it's already going to go into those over-policed communities in our, in our jurisdictions. But we also know that they're not being they're not being given extra money to do it. So I think we kind of talked a little bit about all this, except to, just really emphasize that it's impacting already disproportionately advantaged communities. Oh, question. Oh, yeah.
It's anytime you have a resistance test performed, they are going to run your sequence again and re-upload it. Yeah.
So the specific lab that collects genomic sequencing, I sometimes compare this discussion to when you're trying to do paternity tests, right? And you're trying to prove that someone's a father. Well, now there are all these ancestry.coms, right? That you put in that information and it will forever live there. And anybody that might show up, if your father had 10 children somewhere else and that genomic sequencing becomes close enough to that, they'll tell you have relatives, in other places that you didn't even know about. So they will have collected, the only time they will collect genomic sequencing data is when you have resistance. And once they get that, yes, you're in the system forever and ever. And if you were, and that's why they even said, and they compare it, right? It lives in public data, some kind of public database, so that if you were to have sex with someone, well, let me not even put it like that. If it was to show up that your genomic sequencing data shows up, you had relations with someone in this state and it shows up in another state, they can find that now. They can see that these two genomic sequencing are very similar. what I hear is that now, and I don't know whether this has changed, but we know in the DMV, they started not just collecting it when you are, resistant. They collected it at least once for every person, and they called it the DC cohort. And so they have out for as long as we had done blood work, our consent when we do our labs apparently covered any kind of research that they were going to do on that blood. So that's why we fought. I never remembered giving consent for any genomic sequencing of my blood, but for somehow it was covered at some point when it was taken from me.
I'm just thinking how we are used to enable some situations, like for example, not the actual pasta. We are part of the public health discussion in King County and part of the epidemic advisory group that we review all these reports and consent to some of the interventions that were being taken to this specific street in North Seattle. But I'm just imagining how ignorant on my side, because I'm there representing people living with HIV, not being able to ask questions, and looking at that, we have to fight back. I'm thinking then, what can we do to be more proactive, to be able to question those languages that are being used in that discussion, or even the sentiment itself.
Yeah. And that's what we're about to talk about, but those are the right questions. I sat on planning council for 2 terms, that's 6 years. And I never understood some of the stuff that we were approving for them to do. And that is the objective of these sessions, is we want to get this information out there, because I honestly don't believe, like those clusters that we showed, did every one of those people, had they all had resistances in their past? Like, how did it all of a sudden, a whole section in Seattle, everybody had somehow given consent to do their genomic testing? I don't believe it was only done when it was a resistance episode. I believe, based on what we have said here, they at some point after that announcement, they started collecting this data routinely from people somehow. Oh, earlier.
Yeah. Okay. So, oh. And that makes sense when you actually walk into a doctor's appointment and it tells you, you know what, the medication you're using before, there's something wrong with it, we need to change it. Without you even thinking twice, like, okay, this is my doctor, he knows what is best for me. Okay, they already had a meeting, they already know what they wanted, right? And they know that all they need to do is just to change your medication and you'll be in the list, right? And boom.
I did have a question. It's about housing, basically. I live in a place where I live with people in apartment complexes through Wine White and through the city of Houston for housing for people who live with HIV. I did have a question on it because I had a concern about it because I'm living there. I've been living there 4 years now, up to 5 years, and in the past 2 years, when we reapply for housing every year to stay there, they asking for your CD4 account and all your other information. And I'm questioning that because it does not make sense to me. It really doesn't, because they already know, when you get a consent from your doctor, something from your doctor say, hey, this person has HIV, that's all they need to know. And that's it. Don't need to do my CD4 count and don't need my any other count at all. So I'm questioning that. And we don't know what should I do to actually raise that awareness, to question that and talk to someone about it.
Woo, I think you're saying you have your own answer. See what happens, refuse to give it, question why they need it. Don't refuse, just ask, why do you need that? I don't think you need that, because I also see that in situations when you get access to people living with HIV and you get a chance to survey us, y'all be throwing in the kitchen sink. We get asked questions nobody else gets asked. Never mind, you've been given a life-changing diagnosis, and then you want to sit there and all of a sudden, I'm a grown-ass woman, now you want to ask me about my sex life.
Exactly. I mean,
I
that's what it
mean,
is.
there's no other instance when you walk into a room that people feel that they're entitled to know. You know, I remember talking about U equals U somewhere with Houston health workers, and I said, "Well, what about it to a worker who works at one of our clinics?" And she said, "Well, but we don't know who y'all having sex with." And I said, "It's none of your business." I didn't even think. I mean, but she really said that to me, and it is the thinking. So I think you need to ask, what do you need that for? Why do you need it? I don't really feel comfortable sharing that information. Start there, because we don't want you to lose your housing, and this isn't about housing, but I think you have to begin to question. I looked at one survey, so thank you, Selena. I think you should question, but I remember seeing this one survey that's a part of the Compass Initiative, and they had a question on there, do you believe in God? I remember thinking, why the hell? I'm not kidding you. It was on the survey, and I had to push back and get some other folks to help me push back, because people thought why I had a problem with it. When they went back to change it, then they thought they solved my issue by listing a lot of Judeo-Christian religions to see, are you one of these? Never mind, that wasn't their business either. How does that relate to my living with HIV? But if I'm coming in for your service, you give access to just treat me like I'm inhuman, I'm a cluster, I'm a CD4 count, and I'm a viral load. That's what it gets equated to. So you should ask the question.
I've once asked that question. Yeah. So I just wanted to answer her. I've once asked that question, and they tell me that is part of the requirement for housing. And
I'm telling you, it's not.
and they also tell you that they wanted to know if you are taking your meds or not and everything.
But you still, but still, even that answer, you would ask, but why? Don't never stop with the answer. Why? Show me where that rule is. Why do you need that? Bring 2 more people back and ask why. You bring 3 people, sign a petition and bring it back. So don't accept the answers that don't make sense, because they probably don't.
I wanted a clarification, and then I had a question. You mentioned that the information is declassified, that they are collecting, or is it name identified in some places? Clarify that. Mm-hmm. Right. Right. Mm-hmm. Mm-hmm. Okay. Okay. And the other part, I mean, I don't understand why they're needing all of this. They were already collecting data. I mean, they collect epi data and they report on epi data. So I just don't understand why. The health department, if the health department, I just kind of heard in our area that the health department was going to push back and was not going to provide the information. However, if you're receiving federal dollars, are you forced to provide the information? Are you mandated to provide it?
Ah. And that's why we didn't completely feel protected. I think I said it at the end. We know that even if our health department came to us and said, oh yeah, just to make us, I don't know, we are going to have a policy in our health department that says we will protect this data. We will not share it with law enforcement. I can't remember exactly what our language was. One of the things we said, because for example, DC doesn't even have any specific HIV crim laws, but they'll get you for spitting, for, it's covered under sexual transmitted diseases, whatever. But we also knew that because they are mandated by the state, when CDC says you got to share it, they share it. We also knew that we might not be fully protected if it's a federal investigation. If it's a federal subpoena, we knew that data could still be handed over. So that's a really great point.
And I want to say too, the sharing data is state specific. So each state has their law. I think there's someone over here if you want to get one. And and I'll say you should check your state. In 2015, one of the laws we fought against and won, they wanted to be because our state says they won't share with law enforcement. They want to make an exception and share certain confidential medical records with law enforcement pursuant to first they said just a grand jury, then they said criminal proceedings. So you know which confidential medical records they wanted to be able to share was ours. And because when you looked at the legislative history, they were trying to be able to introduce the HIV records of a guy that was being charged with sexual assault of a minor. And so he was a child molester who happened to be living with HIV, and they were trying to introduce a law that would get us all in this subpoena to be able to introduce his information at trial. So look at your state specific law and figure out what, because we're going to talk a little bit, and I think you're doing data protections. Or, oh, okay. Because all the data protections and uniform information sharing is a problem, and we have no protection. We don't know each state by state, and the CD says we're encouraging them not to share it. That's as far as they go. So you don't know who's going to be sharing unless you look at your state and see what the laws are, and then continue to fight, because this one came up. You wouldn't even notice it if we didn't have a champion who said, y'all might want to look at this language because HIV was nowhere in there. Right.
Okay. I'll just, okay, go ahead.
Are y'all, I just walked in, excuse my tardiness, on that second question?
Yeah, that's where the conversation went, which is perfect.
Okay. Okay. On the second question, when it says EG ending the HIV epidemic, I know everybody is not, get the funding under the EHE, it's only for certain areas. But my concern is where I work at, I work as a prevention specialist, and we brought this question up. I don't know if it's in-house or where the data is going to, but one of the questions we have when we go out and test people, what was the age of your first sexual experience? And it's kind of hard because, when you're testing women, I'm not saying like testing women, but when they say 3 years old, it was oral sex, but vaginal sex was 5 years old. And sometimes you don't know how do you leave that person after they answer that question. And we keep asking, why are y'all asking the question, what's the age of your first sexual experience? And I don't know where the data is going. We try to find out where the data is going. I don't know whether they got a contract with the CDC, but that's a hard question, And with sometimes people say, well, I done got over it. But I'm trained in counseling, but you do no harm. And you don't want that person to leave there with, if they done blocked it out, now I'm going back to my father. Now I'm going back to my uncle. Now I'm going back to my brother.
Okay.
If they done blocked it out. So that's one of my concerns is sometimes on the questioning. I know everybody have a different type of questioning.
Yeah. Rocks. So yeah, I'm actually a little triggered. And we all know that our community has faced a lot of trauma. And we all wonder, why these questions are asked. But I think it's also good for us as advocates to always tie it back to the systematic oppression and systems that are there to put us down. Ryan White was created as an emergency act. And when they're collecting stuff like CD4, they only wanted to give certain services to people that were on their deathbed. You know, that's how you qualified for disability, or you qualified for a bed, because you were on your way out. You're about to die. They did not expect you to live anytime, you know, much longer. And we know that we have evolved. Why we as a caucus and networks of people are fighting for quality of life is because now we know that all this stuff is unnecessary. Even the eligibility, right? People stay unemployed because they want to continue getting services. They're afraid to come out of poverty because they feel that that's the only way they're going to get that HOPWA, they're going to get the services, they're going to get the housing. And so this is a larger fight. This is the call to action, really, why we're here. It's not just challenging this data collection at the state level that continues to oppress us and police us. It's to look at the larger policies that are there. The Ryan White policy itself, that is another system of oppression. You know, why do you have to get my income information, all the stuff that we talked about? Why do you have to know if I was raped when I was 2 years old in order to give me money? We've got to fight, you know, because the CDC, the pharmaceuticals, all of these people are benefiting. I mean, they have enriched themselves on our bodies. And if we don't stand up and start questioning why you are asking for any information from me other than you should give me a service, healthcare is a human right everywhere else in the world except for the US. Everywhere it is viewed through a human rights lens. We're stopping people from getting a good quality of life because we want to keep them oppressed and policed. So when we call you to action, whether it is at the state level, the planning councils, it should also be at this level. When we're fighting criminalization, it's systematic. All this is part of these systematic, oppressive policies that are meant to keep us poor and in jail.
You know, so my suggestion is that
Oh.
maybe we move through the rest and then we can stay
Yeah.
for discussion for anybody else.
Yeah.
who wants to stay.
That's what I was going to say.
Yeah.
Mhm. So let's talk about
Okay.
taking action. Okay.
Okay.
So just did you just hear us? We're saying we'll stay a little later here for a minute if you want to discuss those questions more, but we're going to move into the take action part. Yeah. So next slide. So here are some, and folks specifically asked about some things you could do. So if you got your phone, pull it out, because we have a sign on. We have asked and been asking for a number of years, and they keep telling us stop asking, but we're not, for a moratorium on the practice and use of MHS until they can respond to our human rights concerns. Okay. And so we want you to sign on. We want you to share it. We want you to start talking about it. Don't come here and sit in that chair and listen to us and think your job is over. We need a bigger army. Okay. So we want you to sign on. We want you to be uplifted wherever you go. And if you don't know enough, here's some, you ain't got to know it all today. Call, send an email. Here's some information for you. So we want safeguards. We want protections. We want uniform protections. We want you to sign on. We want, anytime you get a chance, to demand that the CDC halt it until they respond to our requests and demands for data, for privacy, for uniform protections, for informed consent. How about that? How about an opt-out? You know, acknowledge that we are people with a bodily autonomy and humanity. At your local, in your local areas, I told you that Houston jumped out the gate before we even knew it, and we're doing it. And we like some of the people at our health department, but we definitely oppose this. And so it's so interesting. We started this in 2017, and then last year, for the first time, our key person, our health department, said, "We made a mistake." She said, "We put the cart before the horse by implementing MHS before we had done any community work." We went out, and it's
she's saying that now, and I appreciate it, but it's still already done. So we need you all to begin asking the questions in your local area. This is the best place to fight this, is in your local areas at your planning councils. Don't let them tell you we can't talk about it. What you do is after the meeting, you get somebody, you write it out and let them come in and do a public comment if you can't bring it up. Bring this up. Your local ending the epidemic. Remember, the respond pillar is what? It's about surveillance. So when you sit at an EHE table and you say think you're doing good work, you know you're supporting MHS if you don't say something. In Houston, we created a 5th pillar, our quality of life pillar. And now I'm waiting to see the health department if they're going to reproduce that old plan that includes cluster detection, when we done told them we don't want it. We're going to write a letter of non-concurrence. So if you and your local communities, you're ending the epidemic task force, want to sign on to the ending the epidemic plan and you don't agree, write a letter of non-concurrence. We do not agree with it. If you might not think it go anywhere, but get it signed and send it to HHS, send it to CDC, send it to anybody who will listen. We've got to keep bringing this up at every angle. And if you are a person living with HIV and you're in here, join us. Do we have a slide for the caucus? We probably don't. But some of you were in our caucus thing this morning, but we'll make sure folks get this. But join the caucus when you see an opportunity to. We have a membership meeting coming up June 27th, I think. And when you see something, join the caucus. Help us fight this. Fight it in your own support groups. Bring it up. Did you know this? Because most people didn't know it happened. Even sometimes your doctors don't know that they're doing this. So I'm not mad at my doctor, but my doctor works for me. I don't work for him. And he doesn't get to just tell me medication. He don't get to anything he says. We're not equal on this. And I'm one of those people that will not say we are partners in my care. Partners have equal loss and gain. We ain't partners. I'm the chair of this board. Everybody gets to give their opinion, but I'm the only one to go home with this. So unless on this partnership is equal losses, we are not. They are there to give me information for me to say what I need, and then I make the decision. So if decisions are being made in your care that are not with you at the head of the table, and I wasn't at first either because it felt too big. And when this stuff didn't make sense, I said nothing. Now, if it don't make sense, it probably don't. If it don't sound right, it probably isn't. So here, oh, we have another one. Okay, here. So yeah, oh God. So what I was telling you last year, so we've been advocating at our President's Advisory Council on HIV and AIDS. It's short for PACHA. How many of you have heard of PACHA? If you haven't, Google it. This is an advisory council that's under the White House, that's answerable to the Health and Human Services, and they give advice and counsel on HIV matters. We have been working with them because of our efforts. Let me say this: we've been pushing against this, and folks have been saying it's out the barn. Because of our work, PACHA decided to take up this issue and really begin to address community concerns. If we'd have listened to people before, we would have stopped, right? We ain't got what we wanted yet, but we have made an inway, so don't give up. And they started holding these meetings, and they held 2-day meetings in Atlanta last year where some of us were invited to the table. And out of our conversations, although you could see CDC was not really receptacle for being in that room, but we were all in that room and we made recommendations, and that's when they had their attorneys in the room. But later, through the PACHA Stigma and Disparities Committee, we helped draft a resolution that PACHA has issued now, asking for the things that we are asking for in our demands, and asking for a moratorium. And the CDC thus far has refused to even accept the recommendation, the resolution from PACHA. And so we want you to start saying, what about this resolution? Push it. Why, if this advisory council has told you this is what we want, you can Google and get the resolution, you are not listening. So use that resolution, get it, and use those arguments there to say these are the things we want. CDC should listen to PACHA and taking input from the community about what we need to happen from cluster detection response and molecular HIV surveillance.
So there's actually a PACHA meeting coming up in a couple of weeks at the end of this month, and you have the opportunity to provide public comment there. You can register and deliver public comment virtually on Zoom. So if you sign on to our moratorium, we'll have your information and we can follow up with you with the details about how to do that. So make sure you signed on to that moratorium to end molecular HIV surveillance. And I think we'll talk about this a little more maybe in the plenary tomorrow.
Is a guide about how to talk about molecular HIV surveillance. This guide was created by the Center for HIV Law and Policy, the U.S. Caucus, and CWN, specifically for the purpose of answering the questions that we have heard most often folks push back on us with. We have been fighting with the CDC for years. PWN and the caucus have been fighting with the CDC since before I was on with PWN about this issue. So we hear the same refrains over and over again. They try to use the same arguments. So what we've done is created a guide anticipating those arguments. We've also created like a little short blurb that you can say to describe what MHS is quickly and easily. Here we go. Okay, wonderful. So if you scan this QR code, you're going to get a much prettier version that's actually in color. I highly recommend that you do that. Okay, so like I said, you have a very simple explanation of how to talk about MHS, and you have a highlight of what our top concerns are. We have gone over every single one of these today. If you don't have them all memorized, that's fine, because we go into them in greater detail along with the common questions that are asked. So, for example, what we have had before, Nana mentioned this. When we talk about the concerns around molecular HIV surveillance and the intersection with HIV criminalization, and that this surveillance practice that's going on without any guarantees that this data is not going to be shared with police, with immigration enforcement, with prosecutors. Some of the pushback we hear is, oh, but that's not a real concern. Just totally dismissive. That doesn't really happen. That has not happened. They put the burden back on us. They say, point to a case. And so we have some talking points that you can push back on to be very clear that we do not want to wait for someone to be criminalized by using molecular HIV data. We need to have data protections in place before that happens. We know what happens when data is collected about people who are criminalized because of a health condition, because of who they are, because of how much money they have. We also have talking points around how data protections aren't in place. So you can talk about, like, for example, that there's CDC guidance for sure that they provide to states around what data protections they expect to be in place, but that has no teeth. That is not law. That does not actually protect anyone. Other common things that we hear that is actually quite offensive. I think I pulled this one. Another thing that we hear commonly that you'll find in that brochure is that we do this kind of surveillance. It happens. We do it for things like salmonella. They actually said this, and the CDC actually said this in a meeting.
Wait, Tom Leitner, I remember him saying, well, we use this technology on zoo animals.
What?
And there were 3 people living with HIV in a room of 50. And I said, excuse me? We're talking about people living with, but we use this on zoo animals, you know, the study. Oh my God, y'all know I was ready to throw some tables. I'm the only Black woman in the room. He's like, shine the light. I was
talking about people living with HIV and you would compare zoo animals to an argument I'm making.
Mm-hmm.
I'm sorry, go ahead.
No, you should know. It's horrible. Yeah. And so there are talking points in that guide for how you can respond to the most common situations that we've heard. So what we recommend is, go to your planning council, go to local bodies, start raising questions about MHS, find out how it actually happens in your jurisdiction, learn about what protections are and aren't in place, and start to really push back on why MHS is a problem and demand that MHS activities be stopped until our human rights concerns, our data privacy concerns, our security concerns are addressed. I would like to invite, do y'all want to add anything?
No, I think you have it on here. Always push back if they say, if you don't have an example of where it was done, always point to DC, and we can provide you the link to that law as well. Like, this has been done somewhere.
Yep, it's possible.
And that was just like,
Yeah, it was very recent.
So I think one last thing we want to make sure folks know about is we have these super cute stickers designed by the one and only Victoria Siciliano, who's sitting there at the back, PWN's communications director. This one says protect HIV rights and MHS, which is a hashtag that we're using. This one is, does anyone remember the clusters cereal from back in the day? This is a humans not clusters sticker. So take these, put them somewhere prominent and visible, rock them, especially if you're going to any places where you're going to see surveillance people, prevention people, CDC people. Make sure they're really visible on your water bottles and your laptops when you're headed to USCHA. If you're going to any kind of like HIV prevention or surveillance thing, we want them to see that there's a lot of people who care about this issue deeply, right? We want them to get that. So one way we can do that is make it visible. So Alex is going to be at the door on the way out, and you can get some stickers from them. Oh, you know what? I'm sure they can be. That's a great idea. So that's the end of our official presentation. I do want to say that some of us are available, I think, to stay and have additional discussion with anyone who wants to stay. We want to respect y'all's dinner time also. I cannot leave this space without acknowledging our comrade Marco Castro-Bojorquez, who really led a lot of this work with us, and yeah, in whose name we do a lot of this work. And even the graphic that was on the first slide with that little hummingbird, that colibri, that is a bird that he used a lot in his representation. He gave us that image to use. But Marco, for the last HINAC that happened, the virtual HINAC in 2021, Marco and I and some others were actually working on a presentation on molecular HIV surveillance to be delivered at HIV is Not a Crime in 2021 when he passed away. And it was just 2 years ago this week. And we, literally the conference was like a few days after Marco left us in this plane. And so he was still in all the presentations, and his spirit and his guidance and his fierce commitment to communities that are so vulnerable and so policed and surveilled, and the love and dignity and human rights vision that he had for all of us that drove his work really is the legacy that we want to continue to carry on. So thank you.
Thank you so much for being here. Thank you.